All right, let's go ahead and get started. So this is going to be part two of the vasculitis talk that we started off with last week. If you guys recall, last week we went over the small vessel vasculitides, which included those that were associated with ANCA versus those that were associated with immune complexes. The ones that were associated with ANCA were old school kind of Wegener's granulomatosis, microscopic polyangiitis, and Churg-Strauss. And we were talking about how we started from Churg-Strauss going to microscopic polyangiitis by using this eosinophilia, asthma, and granulomas as a marker. As you lose one or the other, it kind of progresses from Churg-Strauss to microscopic polyangiitis. Again, these are small vessels, so it's going to be in organs such as your distal extremities, some Raynaud's, as well as your renal system as well. But the Churg-Strauss, and we actually had a case last week on the inpatient team where that was one of the suspicious conditions because this patient had eosinophilia, but they had it primarily in their lungs and the BAL, not as much in the blood, which is one of the markers that's required, and as well as asthma. So if you have someone with asthma on your boards with eosinophilia, what they're getting at is Churg-Strauss for the most part. Do you understand that there's two different types, major types of asthma? There's your allergic and non-allergic. Your allergic type asthma is going to be the one that, I apologize for my dogs, versus your Wegener's, which is not going to really be associated as much with your eosinophilia. And then we talked about the immune complexes, cryoglobulinemic. We went through the C1, C4. Oh, I'm breaking up. Am I still breaking up, everyone?
No.
All right, so maybe it's just Basco, maybe it's your internet connection. And then HSP, which was associated with those specific palpable peripheric lesions in the distal extremities, and it was associated with abdominal pain, with IgA deficiency. And then we briefly talked about lupus just because it's its own topic in itself. So that was just a quick review. So let's go over part two. So we're going to get into the medium and large vessels. In your medium vessels, it's going to be they're necrotizing with the lymph node involvement versus necrotizing arteries without. You're going to have Kawasaki's and PAN. So let's talk about PANs first. Again, just like I talked about last time, we're not going to go through each one of these lines. The ones that I've highlighted are what you really need to know because either they're unique for that condition or that's what the boards or in clinical practice is going to help you for distinguishing. So for PAN, you're going to look for this livedo reticularis, which I'll show you a picture of in a second, but it's kind of this lacy-like purplish hyperpigmented rash, usually in the abdomen as well as the lower extremities. In men, it can be associated with testicular pain. It's not common to have any lung or heart involvement. So when you're doing your workup for a vasculitic condition, which we talked about last time, which would be more systemic symptoms with fevers, chills, B symptoms, et cetera, and you're trying to differentiate what type it might be, then know that when you have lung involvement, so maybe some hemoptysis or sinusitis, et cetera, upper versus lower lung involvement, it's probably not going to be PAN. What you're looking for is really the kidneys, though. So you're looking for hematuria, proteinuria. You might not necessarily see significant red blood cells or CAS, I should say, red blood cell CAS. So it's not going to be really a glomerulonephritis. It's just going to be overt damage to the kidneys with microaneurysms. The ANCA, that was pretty much what we talked about more for our small vessel disease, but in here, the ANCA is going to be negative. This one I put in pink, the Hep B infection, they love to ask you on this, but it's going to be on active infections, not just an antibody. So they give you Hep B antibody that happens to be positive. That's not something you're considering with PAN. It's going to be an active infection because then you're going to treat that infection in hopes that it's going to resolve PAN. But again, it's not common, but boards like to test you on it. Remember, we talked about the fact that you're going to see some aneurysms, as renal artery microaneurysms. So if you were to do an angiogram of the abdomen, you can see that this large organ here is going to be the liver, and then you're going to see the distal aorta, and it's branching with the spleen here, and then it's going to branch to your left and your right kidneys. So you can see in this situation, this was a 37-year-old who had these non-specific symptoms with elevated inflammatory markers of CRP and ESR. And they found that the reason why it looks like aneurysms is just look at the change in the vessel diameter between like here and here. And you can see that there's just multiple different changes as well. This is kind of hard to really see the microaneurysms here, but it's just the overall change in the vessel diameter as you kind of go. And it's not like it's getting thinner as you go distally. Here you can see it was thick and then thin and then thick again and then thin. So this was someone that was diagnosed as having PAN. And then this is what the levator reticularis might look like. This is not the most common presentation in terms of the rash itself. The levator looks more like this purplish that you see here, and again, it's going to be lace-like. So these lesions are the ones that are more common to see. Otherwise, if this was maybe in your shins, it might look more like your HSP type picture. But this was a person that had it primarily in their foot. And clearly, if you have any question of the diagnosis, you could always get a biopsy. This is from Visual DX, which is a site that focuses specifically on dermatologic conditions as well as systemic conditions that can manifest with a dermatologic pattern. And we know that the fever, malaise, these non-specific symptoms are very common with our vasculitic conditions in general, but this levator reticularis is what they're going to try and focus on, as well as, and the diameter of these red markings are, the wider the diameter, the larger the circle, the more common it's likely to see. So abdominal pain, myalgias, arthralgias are non-specific, but the levator, if we were to have the distal extremity showing on this picture, that would be kind of a large diameter circle, because abdominal pain and the levator is what they're going to ask you about. So how are you going to diagnose this? If you have someone that has the non-specific symptoms and maybe they do have a Hep B surface antigen that's positive, and potentially you get a PCR and there is detectable viral load and you're suspecting it, you're going to need either a biopsy or that angiogram, which I showed you. You know, it depends on, I think in our population, and maybe in any population, when you're trying to think about the risk or the cost aspect of it, you could argue that the biopsy is probably the cheaper option, and it's probably not going to be as risky because this is going to be on the skin in the lower extremity. So it's not going to be a pretty invasive procedure. But if for some reason you can't do that, or maybe you don't have the ability to do a punch biopsy, and that would be the type that would be recommended a punch, or you're just not able to do it, then you can get the angiogram to look for those aneurysms. And that would be pathognomonic if you see the microaneurysms in the abdominal vasculature, specifically the renal vasculature. If you don't have any option of either of those, you could get an EMG looking for this mononeuritis multiplex, these various regions of neuropathy that is not necessarily associated with upper motor neuron cause in the spinal cord. The treatment, as we've talked about with the previous vasculitides, it's going to be steroids, high dose steroids. And then, excuse me, you can use cyclophosphamide if you have a condition where it's just not responding to the steroids. You know, if you were to ask me, like, how long would you wait? I wouldn't know. I'm not a rheumatologist, but I would say that probably within 3 days, you should see some improvement in the ESR and CRP, which you could use to help trend it. Going back to my talk last time, do you recall which of those between ESR and CRP was the most sensitive and associated with a quicker change in acute pathology? Anyone? No, it's the CRP. So the ESR, remember, it's going to be associated with multiple variables that can affect the normal. We talked about the gender specifically, as well as the age. But as I talked about, the CRP is going to be quicker to change and become abnormal. So it's not uncommon to see the CRP be elevated. So I wouldn't say the ESR is faster, Dr. McMillan. I would say that both are non-specific. So I wouldn't use that term better. The CRP is going to be faster to actually change. The ESR will change, but it's actually going to take a little longer. So but the point that I was trying to get last time is, just because you have a CRP that's abnormal, but an ESR that's normal, doesn't mean that it's a false positive. It might mean that you're detecting this very early in the clinical course. But if you have both that are elevated, this might be someone that's had this brewing for a while. You know, depending on their history, they might say, oh, I've had these symptoms for a few months, versus a few days ago, and then it prompted them to come to the emergency room or to get you seen in the clinic. The board points, mononeuritis multiplex, they really like to focus on that specifically for PAN, but I think the easier one to remember is just the hepatitis B acute infection rather than the antibody itself. So let's go on to now Kawasaki's disease. We know this is associated with our Asian population, especially in children that are less than 5. When we have these fevers that are lasting for multiple days with no clear cause, and then when you're doing, clearly don't do pediatric patients, but if you recall, maybe during your rotations as a medical student, this was clearly something that was always in your differential, that we saw this kid that's usually of Asian descent, and then you had bilateral conjunctival injection with that strawberry tongue. that was something that you immediately consider, oh, maybe this is Kawasaki disease. But the big concern that we have is the fact that it has medium vessel involvement, which we'll talk about later. And that, or I guess I'll just kind of mention it here, and that medium vessel involvement is what leads to coronary arteries being involved, which is why it's one of the rare times we ever prescribe aspirin to a kid. Even though this is a pediatric condition, this is fair game for your boards for internal medicine. We don't know if it's caused or induced by underlying infection. So if they had an upper respiratory infection that eventually led to this, kind of like our rheumatic fever type patients that didn't have treatment, that's really up in the air, and it's kind of controversial about whether or not it is. But for now, we really don't know what causes it. Just know about that association with the conjunctival injection, as well as the strawberry tongue, which is shown here. And then if you look at the lower extremities, this is the knee, you'll see that this patient will have, or the patients will have, multiple pustules throughout. It's kind of a lace-like, again, non-specific erythematous rash with overlying punctate and plaques, as well as some pustules that are present. And if you were to do a fluoroscopy with contrast, and this is an angio, to look at the aorta, so this is the aortic valve that's showing here, you can see there's just dilation as well that you can see with that, as well as primarily the coronary vessels. So the coronary vessels, they showed it here, but what they're really focusing on here is hopefully, I don't know if, I think I might have been using my mouse on the wrong screen, so I apologize. This entire time I've been pointing at stuff that you guys can't see, but the coronary vessels is what they're focusing on this picture. So learning points for your medium vessel vasculitides, we talked about PAN as well as your Kawasaki's. PAN is probably more likely between the two to be something they're going to test on, just because it's associated with adults specifically, but Kawasaki's, again, will be still for a game. Know about with your medium vessel, it's going to be associated with, not specific symptoms just like others, but with PAN specifically, it's going to be an acute hepatitis infection, as well as that mononeuritis multiplex. So Dr. Patel said, I read as internists, adults who had Kawasaki's are at lifelong risk. Absolutely. So that's a great point. So as a kid, they're put on aspirin 81 milligrams, and they'll continue aspirin lifelong at that point. I don't know if they recall screening imaging and what that would entail, whether, clearly we wouldn't do screening coronary angios or even CTAs. So if that was a question that was initially brewing in some of you, I don't know the answer to that, but my suspicion would be no. But if they have symptoms otherwise that are suggestive of chest pain or even vasospasm, something where you're kind of in that intermediate risk, you might push you to doing more of an angio instead of a stress, just because that person is at higher risk. So we've gone through a lot so far between the two lectures. We did, and this might be a smaller or a shorter lecture just because we got through a lot of it last time. But we talked about the small vessels. I went through that full differential and the different conditions just now. Then we finished up on the medium vessel, which is going to be a lot of your coronary as well as your renal vessels, which included PAN as well as Kawasaki's. And now let's finish up on our large vessel vasculitis, which is going to be GCA and Takayasu. GCA clearly being, I think, of all the conditions, the one that we're more likely to remember or keep in our differential. Whereas I would argue that a lot of us aren't really considering PAN or even cryoglobulinemia vasculitis or HSP as much as we would for GCA. So for our large vessel, again, PMR, GCA, as well as Takayasu. So let's start with giant cell and PMR. These are going to be your older patients, average about 72 years old. And instead of like PAN or Kawasaki's, I should say, where you're going to have coronary vessel involvement, GCA being a large vessel involvement is going to be more affecting of your aorta and the major branches like subclavian and the carotids coming off of it. So focus more on the carotids and the vertebral arteries in these patients. Clearly another reason why if you have maybe a GCA patient and you're treating them with prednisone, remember, you're not going to wait for that biopsy. Just as a knowledge check, how many weeks do you have before your biopsy may have a false negative after initiation of steroids? How many weeks? Basically, do you have that window of safely giving them prednisone? Anyone? How many weeks? No, it's 2. So 2 weeks you have before, yeah. So Dr. Makwa, Arkan, and Mathew. So 2 weeks is after 2 weeks, then there's the higher risk of having a false negative on your temporal artery biopsy. So clearly you're going to put these patients on prednisone, and then if you need a CTA of the neck or MRA, then you can get that to focus specifically on the carotid and vertebral arteries to make sure there's no dissection. But these are some other vessels, clearly the temporal arteries, that can be affected in these patients. They'll typically present with scalp tenderness palpation, as well as sudden onset loss in one eye, so the amaurosis fugae, as well as jaw claudication, pain with chewing, talking. So you're not going to ask them, do you have jaw pain? You're going to ask them, hey, have you noticed pain maybe when you're eating food? Or maybe when you're talking to people that you feel a little more fatigued or sore. That's how you're going to want to ask these patients. Just like when you're trying to rule out hokum in the family, you're not going to ask, do you have any families who have suddenly died? No, you're going to ask them, do you have any family members who died because of unexplained, unusual circumstances? Maybe they got in a car accident, they drove off the road, things like that. Whereas with PMR, you're going to include it in primarily, like I mentioned with GCA, we're good about having it or differential, maybe not as much with PMR. But when you have bilateral upper extremity pain, worse with use, and it's better with rest, those are the patients you should still have PMR in your differential, right? That proximal pain, hips, shoulders, et cetera, the hip girdle. Labs, ESR is going to be pretty high, greater than 50. CRP, I believe 0.4 to 0.6 is like the cutoff that we have, at least in our clinic or in our hospital. The levels of elevation do correlate with, well, I wouldn't say they correlate with severity, but they do correlate with the amount of involvement. So if there's multiple temporal arteries involved, axillary, subclavian, et cetera. These patients will have a reactive thrombocytosis secondary to the profound amount of inflammation that's present, as well as an elevated alk phos. That I don't know why that's elevated, but it's kind of a unique thing that you might see in these patients. Whether or not it's because of mesenteric and artery involvement, I don't know, but I would argue that it's probably not that. I mean, the mesenteric arteries, I would say, is more suggestive of medium vessel, which is why it's under PAN. So I don't think that alk phos elevation is secondary to involvement of those vessels specifically, but I don't know, to be honest with you. I did try looking and I couldn't find specific data on that. So how are you going to make the diagnosis where you're going to have clear clinical suspicion in the right patient with that jaw claudication or pain, temporal artery pain, maybe some intermittent vision loss or changes, and headaches? So that in itself would be enough to start them on prednisone, and then you're going to try and go after a biopsy. You can get imaging to look, and we've focused a lot recently on ultrasound because it's not invasive. I wouldn't necessarily, it's faster to do unless you're, comfortable in getting ultrasounds of the temporal artery, but I know I'm not. So I think, but it's more from a cost perspective, it's a lot cheaper for patients. More recently, they've really been focusing on PET CTs. I think that's also because it helps you from a localization standpoint for the vascular surgeon. Pretty good sensitivity, up to 85% for a PMR, up lower 71% only for GCA. But the ultrasound can actually look for, if you're looking for PMR specifically, remember if you have shoulder issues and you're not focusing on GCA with temporal arteritis, you could look for bursitis in the shoulder itself, which might be suggestive of underlying PMR, a reactive bursitis from the inflammation. But the big thing that you really want to do, if you're not going to be able to get an ultrasound, PET, or even a CTA or Doppler in the ER, then you're going to try and get that biopsy. So you're going to get vascular surgery involved. You have that 2-week window, which you talked about. And you're going to either ENT or vascular can do it. I think based on the ENT, I would argue that it's dependent on your location. So here we have vascular, so clearly we'd probably be able to go to them for it. But maybe if you're in another rural hospital and you don't have a vascular surgeon, but you do have an ENT, remember that you could ask them for the ability to check it. The second bullet's important because they do like to, clinically, it's important as well as for testing purposes. If that initial biopsy is negative, but your suspicion is still high, you shouldn't just stop. It's kind of like thoracenteses. You increase your suspicion or your sensitivity with each subsequent diagnostic tap. But instead of biopsy the same side, you're going to biopsy the opposite side because there's a false negative rate of up to 10% with just that initial biopsy. Again, don't don't withhold steroids just because you're waiting for a biopsy because you have that 2-week window. And then why do we treat these patients? Because they do have a high stroke risk, 1.5 to almost 7%, pretty wide range, but I'd say that's pretty high up if you compare that to some of our AFib rates in patients who are not treated with anticoagulation. And think about it from that standpoint with your CHADS2 VASC. I'd argue, in your CHADS2 VASC scores are like 4 and below, we're seeing similar stroke rate percentages. So this is just as important to treat these patients with your steroids to decrease inflammation, which will subsequently decrease their stroke risk. And if you were to do that biopsy and you have a pathologist look at it, this is what it's going to look like. You're going to see this significant amount of inflammation going around that blood vessel. So this is what they're looking at. Just see how thick this vessel is and how this is the actual vessel patency, and it's just kind of completely obstructed because of all this extra inflammatory mediators that have infiltrated the tissue, which is what increases that risk for stroke. But in order for you to focus on PMR, a lot of times I think we group GCA and PMR just because they're large vessel conditions too, but I wanted to focus specifically on PMR also and just make sure that we're not forgetting it. This did come up also on rounds for our patient last week, is that, well, if we had GCA in our diagnosis or in our differential, this is one of those times where you should get an opto consult. Interestingly, in this situation, opto was the one that sent the patient to the hospital if they complained of any visual symptoms. But in our situation, Dr. Carroll, and he astutely had noticed that the ESR and CRP were negative. Now, if you only had an ESR that was negative, but you didn't for some reason have a CRP, again, that's not going to necessarily rule out the condition just because of that delay in elevation that you can see with ESR. But steroids will be your first line treatment. It's going to take about 2 to 3 years, right, for that potential. I would say more a year that patients are on treatment, but it's not uncommon for them to be on 2 to 3 years. And the reason why is because you're decreasing the dose. You're starting not only with a high dose just to get immediate relief of symptoms, which might be visual or even like back or musculoskeletal symptoms, but it's the fact that you're decreasing the dose very slowly in 1 to 2 week intervals by small amounts. So again, it's a marathon, not a sprint. And because you have this low, starting at a high level, and then you're just slowly going down on it, it's just going to take a long time mathematically. The other thing that's going to cause prolongation of treatment is once you're decreasing and down titrating them, which I don't think would be unreasonable for a rheumatologist to have a primary care physician manage this, because really you're going off their symptoms. If you start weaning them off and they say, oh, doc, my symptoms have started to come back, then what you'll do is you'll go back up to the last tolerated dose before you had weaned them down to that lower level. So that's why it can spread out to 2 or 3 years until they get complete relief. And because of that, once you get to that 2 to 3 year mark, they're just at very high risk for osteoporosis. So if you suspect in most patients with GCA, you're not going to get them off treatment in 3 months. So it's not uncommon to just start bisphosphonate therapy straight off the bat once you make that diagnosis of GCA, because the expected duration of steroids that they're going to be on, as well as I would check at vitamin D and calcium, because we don't want to start them on bisphosphonate therapy if their calcium and vitamin D levels are not controlled, or at least at where we expect them to be for the patient. Remember that osteoporosis is not the only risk factor that we're going to see, right? We're going to see diabetes, or our diabetic patients. We might have some very difficult times controlling their sugars. Maybe you're gonna have to go up to an insulin for that small period of time, or add on 2 or 3 other oral or subcutaneous agents. I think that I was watching a lecture from ACOI that was on 2 weeks ago, and one of the big points the endocrinologist was trying to make, I think that we're too quick to starting patients on insulin. And last week on rounds, I was telling the team, it seems like we're just giving up on those patients, right? We've just gone to insulin, but we're not. We know that they have some, unless they're type 1, they have some endogenous ability to produce insulin. So why don't we try and use that to its fullest extent by initiating an LGD2 or a GLP-1 or even a DPP-4 on top of metformin before you got into insulin. So you might try adding these other agents on in these patients that are on these high dose steroids, but it might not be, I guess don't be surprised that they eventually have to go on insulin, but just let them know this is going to be for just a year or two until we can get the steroids off. DMARDs can also be used, but methotrexate specifically just doesn't have a lot of good evidence, which is why most of the patients on GCA and PMR are just going to be on steroids when you see them. And then they'll potentially have like Cushing's and these other side effects from it. Tocilizumab does have some newer data supporting it in an attempt, I would say, not for GCA treatment, for more PMR, because GCA is, something that after 2 to 3 years of treating it, it's kind of gone. But PMR is going to be a more of a lifelong condition for these patients. So they're the ones that you're probably going to see on the immunomodulating meds. And then we talked about the risk for stroke in these patients, secondary to the concurrent inflammation. So you should start them not just on the steroids, but aspirin too. And then knowing they're on steroids and aspirin, this is kind of a read my mind question, but what other medical condition do you think that they'd be at high risk for that you want to try and prevent when you think of steroids for a long time and then aspirin? Not necessarily stroke. I mean, that's why we're doing the aspirin. Yeah, bleeding. So Dr. Nash, yeah, that's what I was kind of thinking of. So your GI bleeds. So these are the ones that you would probably want to put them on a PPI, but just knowing that the PPI also is going to increase your osteoporotic risk. So you're kind of stuck between a rock and a hard place. So I would, in these patients, either an H2 or a PPI would be warranted to start. On chest x-ray, there's a long-term risk, as Dr. Mathew had mentioned, for aortic aneurysms. So you can get annual chest x-rays, and this is clearly not an x-ray. This is an angio. So you might say, well, what is a chest x-ray going to do? Why don't we just do annual angios? Well, angios are going to be expensive. The patients aren't going to be able to afford that, but you might notice some fullness. And unfortunately, I didn't think about putting a chest x-ray to show that. But if you're looking at the chest x-ray of the patient, maybe in the left supraclavicular fossa, you might notice some fullness in the left subclavian versus the right subclavian. So if you notice that, that might prompt you to get an angio specifically versus using the angio for specific screening purposes. So if this is for GCA versus PMR, we're going to start our patients on very high dose, 1 mg per kg, which will end up being about 40 to 60 milligrams of steroids. Or if it's PMR and they've been out for a long time, maybe you'll use your tocilizumab. And you'll look for at least some improvement within 2 to 4 weeks, knowing that long-term complete cessation or resolution of symptoms is not going to happen for multiple years. But once they get that improvement, that's when you can start decreasing the steroids. You can do it by 10 milligrams. There's no real, recommendations of exactly what to do. You're just going to talk to the patient and just get a feel for how long, maybe that first titration is going to be your benchmark. You'll say, okay, well, I'm going to go by either 10% or just 10 milligrams. And you drop them to 50 and they say, nope, doc, my symptoms came right back. So maybe you're going to go up to 60 and then wait another 2 weeks. And then maybe you'll go down to 55 instead. And then, or maybe you'll retry 50 and they said, nope, doc, it came back. And at that time, you're going to be like, all right, well, make sure we're having realistic expectations. I'm just looking for improvement, not resolution of the pain. But you might have to decrease that or the amount that you're decreased by based on that patient specifically. If they have remission, obviously, like I just mentioned, you're just going to continue the treatment. And then eventually, if they're on an immunomodulator, you're going to try and take them off just because of the long-term risks for immunosuppression, TB, hepatitis infections that can present with that. And as I mentioned, you're hoping after 1 to 3 years, you're going to eventually have some complete remission. But if their symptoms reappear after a complete resolution, and it's not uncalled for, but they reappear, you're going to restart. You're not going to go back up to maybe the 10 that you finished at before you completely stopped the prednisone. You're going to restart it. But if they didn't seem to be able to have, resolution of their symptoms, then you're going to treat them for the flare by giving them, 5 to 10 little bolus pushes. So if you're able to get them completely off, great. If not, and you stay at like 20 milligrams, chronically, which we've seen, I'm sure you've seen some of our patients with that, then you'll keep them at 20 and then you might go up on by 5 or 10 for some flares. So that was GCA and PMR. Let's talk about Takayasu arteritis. This is going to be in your younger patients where GCA and PMR, you're older, what we're kind of used to. These are going to be maybe your athletes, 30s to 40s who are coming in, females more than males. They're going to present with maybe a new onset chest pain, headaches, etc., very non-specific symptoms. Just like I mentioned, we're clearly in the large vessel category. So as we'd expect with large vessel, it's going to be your aortic arch, the aorta itself, as well as aneurysms coming off of it, be like subclavian, for example. The unique characteristic of your Takayasu women, and I'll say that because that's the way they're going to test it, is they're going to present with claudication in their extremities. And it's going to be due to narrowing of the subclavian. So if you were to auscultate, you might notice a brewery there. You'd have to use your bell for that because of the size. Most patients don't have a, supraclavicular fossa that is amendable large enough for our entire stethoscope to kind of put for auscultation. Or you might palpate their pulses on both arms and look for decreased pulsation on one side or the other. There's also going to be a change in blood pressure between arms, whereas if it was like upper extremity versus lower extremity, we're thinking coarctation. Whereas with Takayasu arteritis or aneurysms, we're thinking, between the left and the right arm. And again, as I mentioned down here, that bruit between the different, the subclavian might be present. Oh, and what I thought I mentioned it, but as we talked about last time, your young females presenting with uncontrolled hypertension, you're thinking of fibromuscular dysplasia. This can involve some smaller vessels, but it's more like, or medium vessels, but most commonly it's associated with large vessels. So you're going to look for those non-specific symptoms, but then you're going to have some other visual disturbances possible, because when you affect the aorta, it's going to affect the carotids and eventually potentially affect the occipital lobes as well. You'll, on physical exam, look for the claudication, the changes in pulse or lack of pulses in one extremity versus the other, some bruits that you auscultate with the bell on the subclavian fossa, and they might even present with ischemic bowel disease. So when you have someone that comes in that's 30 or 40, maybe they have these non-specific abdominal symptoms that we attribute to, oh, this is just irritable bowel syndrome, but they're not meeting the Rome 4 criteria for true irritable bowel syndrome. That might be a reason why, and it's maybe if they have a history of autoimmune disease in themselves or their family, you might say, I really think this might be Takayasu. And before jumping straight to a abdominal angio, you might get an ESR and CRP and see that it's elevated, which it's not going to be elevated in an IBS type patient. That might lead you to getting, looking for that mesenteric ischemia in these patients and getting a fecal occult and looking for blood. But the way you're going to diagnose it, you're going to look for major large vessel involvement. So CTA of the aorta. You're going to look for that tapering, which we talked about in that first image at the start of this lecture, where it kind of tapers and then it goes back maybe and tapers again. And because of the chronicity, this is not something that just spontaneously occurs at the 30s. This has been smoldering in the background. There's going to be collaterals that are formed that you'll see on the MRA or the CTA as a result of that decreased perfusion. So the body's kind of doing what it can. Because this has been going on for a long time, just like our GCA patients, you're going to put them on steroids. But unfortunately, unlike our GCA patients, they're not going to have as high of a prediction or chance of relapse or resolution. They have a high chance of relapse. So you're going to use that ESR and CRP potentially on a monthly basis to track it. And when you start seeing one or the other going up, if not both, then you might suspect that maybe a potential relapse is happening in these patients. Unlike what we saw with our GCA patients, even our PAN, methotrexate is very helpful in Takayasu specifically in decreasing the remission rate. It's not perfect, but it's a lot better than steroids and keeping these patients on for like 10 milligrams a day for lifelong. Because you can imagine these patients are presenting at less than 40. You put them on prednisone daily for the next 50 years, like they're going to have diabetes, osteoporosis, their lipids are going to go up, their quality of life is just going to be horrible. So if you can get them on methotrexate earlier, this is one of the conditions where methotrexate does have better effects versus tocilizumab in GCA. So this was an example. Again, if you were to get a chest x-ray, you might notice widening of the mediastinum, or we know that we're able to see the aortic arch sometimes, or the knob, in patients that have severe atherosclerosis, because we see that whitening show up on an x-ray as a little ring. But you might notice that there's some rib notching as well because of that collateral vascularization that's occurred. So this is an example of an aneurysm that's formed in a patient that had Takayasu arteritis. So we just went over the large vessels. We mentioned, GCA, the tenderness in the temporal artery might not always be there, but if it's there, it's, very suggestive of this condition being present, as well as jaw claudication. And you're going to initially get that biopsy, but if the biopsy is negative, make sure you biopsy the other side, right? Because it's going to increase your sensitivity up to 46 or so %. You're going to start them on steroids. You have a 2-week window, and then eventually you're going to wean them off very, very slowly over maybe potentially 2 to 3 years completely. But if you're not able to see those remission rates that you were hoping for, then you're going to put them on tocilizumab. Whereas when you have someone with temporal arteritis, Takayasu arteritis, those patients do respond to methotrexate, and you really don't want to use the steroids because they're so young when they present that you're just succumbing them to a lifelong of complications from the steroids themselves. Visual disturbances are very common with GCA. It's not necessarily bilateral, usually it's unilateral, but that amaurosis fugax is the classic presentation of a sudden vision loss. It's not going to be like a curtain dropping with your retinal detachment. And if with PMR, you have to have a high suspicion for it, right? Because we can see patients that present all the time with shoulder pain, and usually they're females, just like our PMR patients will typically present. But maybe you put them on anti-inflammatories and steroid or Tylenol, they get a little better.
but it's just progressing. And maybe you get an x-ray and it's not really showing much at all of arthritis. You're like, this isn't adding up. This patient is complaining of a lot of weakness, not necessarily pain, but weakness. And I'm not seeing any imaging that's really corresponding to why they should have that on presentation. This is might be a time that you get that ultrasound to look for that deltoid bursitis that we talked about, as well as an ESR and CRP, because osteoarthritis is not an inflammatory condition, right? It's not inflammatory. So ESR and CRP shouldn't be elevated in your osteoarthritic patients. And then let's go into some of the specific learning points for those conditions. So GCA, or your Wegener's, your saddle nose deformity, it can affect other cartilage like your ears that we talked about. You're going to see lung involvement with some hemoptysis, as well as renal involvement, your red blood cell cast, and avert blood that's present. So macroscopic hematuria. Your eosinophilic granulomatous with polyangiitis, or EGPA. This is going to be like your Church straw, so the old school term for that. Your asthmatics with eosinophils, you're going to increase your suspicion for that, especially if that eosinophil is mentioned in the blood. It's going to be more than 10. Oh, sorry, there's a question. Dr. Charter had a question. Is there any specific class of hypertension meds preferred for these patients? Sorry, so I might have caught this late. So for which condition? So asking specific class for Takayasu. I have not come across that. I would argue that your diuretics are not going to be the one that you're going to be focusing on. For Takayasu, since there's not much renal involvement, you could argue that even the ACE inhibitors and ARBs possibly are not going to have as much of a benefit. So I agree with you that the calcium channel blockers are ones that are going to focus specifically at the heart and the vasculature itself is probably going to be more of a benefit. But if you see long-term, if these patients do develop, renal involvement because they've had high blood pressure that's not being controlled, and then it leads to renovascular issues, then you could add an ACE inhibitor or an ARB on. But that's honestly me kind of just suspecting and thinking about it from a logical perspective. I can't say that what I said is necessarily based off of data, but I would suspect that based off what I just told you, that the calcium channel blockers are probably going to be your best bet. So then going to the back to the EGPA, again, lungs, kidney involvement can be present, but eosinophils, it's going to be greater than 10% in your blood. But a BAL will probably show some eosinophils as well, and you're going to put these patients on steroids, just like almost all these conditions. Your microscopic with polyangiitis, there's really no lung symptoms. This is going to be primarily renal symptoms. So when you look for a chest X-ray or maybe a high-resolution CT, you're not going to see any granulomas or even interstitial lung processes going on with those patients. Kawasaki's, that's going to be your medium vessel. It's going to be your young Asian kiddo, usually less than 5. They're going to have that strawberry tongue, maybe a little levator reticularis present as well. I kind of showed you those pustules that were present on that one picture, and they'll have some aortic involvement potentially as well, but it's primarily coronary involvement, which is why we're going to put these kids on aspirin for the rest of their life, as Dr. Patel kind of alluded to earlier as well. And then you might see some conjunctival involvement in the eyes as well. GCA, now we're getting into our large vessel. You're going to have the jaw pain, headaches, vision changes. I've kind of gone to that in depth. I just noticed I had a typo. So at the top, it wasn't GCA, it was GPA, so not GCA. And then Behçet's, we didn't talk about that because I said, that's just too much for a lecture. But the patients that you're going to be thinking of with Behçet's is genital and oral ulcers. The minute you see those two areas of involvement, you should immediately be thinking Behçet's. They're usually going to have a picture of an oral ulcer. It might look like an aphthous ulcer. And then they're going to be asking you, what do you, not what you think is going on, because that's a first order question. They're going to do a second order. What do you think is a treatment? And it's still going to be steroids, because they want you to make sure you know this is a vasculitic condition. With PAN, that was another medium vessel vasculitis. Hepatitis B active infection. They're going to present with abdominal pain. You're going to see those microaneurysms in the renal vasculature. So you might have some concurrent hematuria as well. Or they can present with abdominal pain secondary to mesenteric ischemia as well, even though we talked about that specifically with our patients with our large vessel involvement as well. And then finally, cryoglobulins. I talked about this more in the last lecture, but I just wanted to kind of quickly review it again today, just now. Type 1, 2, and 3. Remember, your multiple myeloma and lymphomas, your cancers are type 1. Your type 2 is going to be hepatitis C. And then your autoimmune inflammatory bowel diseases are going to be UC and Crohn's type 3. So the way they'll ask you on boards is they're not going to ask you what type this is unless the patient has concurrent hep C. They're going to say they're diagnosed with type 2. What would you like to screen them for? And they're going to ask you to screen for hepatitis C antibody. Or what would you like to screen them for if they have type 1? And then the answer is going to be getting an SPEP and UPEP versus maybe a lymph node excisional biopsy, right? Because lymphomas, we don't do FNAs, we do excisional biopsies for lymphomas. And then for type 3, maybe they'll mention what other symptoms would you expect this patient to have? And the answer would be blood in the stool or family history. So these are all the references that I had. It was about 24 or so. I finished very early, probably for the first time since I've ever lectured to you guys. But it was only 100 slides to this lecture, and it was only supposed to be one lecture. So what questions do you guys have? This was a lot of information to go off of, but hopefully, using, let me scroll back up. I don't know which slide that you guys can see. Let me just make sure. Let me share this slide. Okay. So, I tried to make it in a way that, was easier for me to understand. So that's why I used this flow chart to, organize things. And now I can't see the chat. Where did the chat go? Sorry. Having some technical oh, there it is. Okay. So again, the small vessel, that's just break it up based on the size of the vessel. And then based on that, then you're going to go off of whether it's ANCA positive or negative. And if it's not ANCA positive, now you're immediately thinking in small vessel, some immune complex that are formed either because it's lupus or secondary to the cold temperature where there's a cryoglobulin that's now, formed, less than 36 degrees Celsius. Or it's from HSP, which we think of, or IgA specifically, and those with abdominal pain, and then that shin rash, versus the medium vessel, it's going to be your PAN and Kawasaki's, or that PAN, hepatitis B. Remember that association of Kawasaki's, it's going to be a kiddo at high risk for coronary vascular disease. And then large vessel, GCA, headaches with the risk for stroke, ophthalmologic urgent versus emergent consult to make sure that you're not having any microaneurysms or stroke or ischemic changes in the eye itself versus Takayasu. It's going to be your females that are going to have aortic involvement with the pulselessness and changes in pulse between the different arms. So Mafus is complaining, what a surprise, that I'm saying vessel. So if everyone can do me a favor and every time you see Mafus, call him vessel and not fessel. And that would make my day. Any questions you all have before I stop the lecture? Hopefully this was an easier way or somewhat easy way or a good introduction to vasculitis, because I know it's hard for me to also remember it too, but that is it. Today is my off day, so I'm not in the hospital, but if you have questions, just shoot me a text and I can answer them. I think I'm going to be finishing up, I don't have my schedule in front of me, EKG part 4 in the next 2 weeks or so. And then this month in November, I'm lecturing 2 more times. I'll be doing a lecture on dermatology as well as GU from a male perspective, because I just don't think that we talk about that, but we clearly see it a lot in the clinic as well as on boards. Yeah, so I'll be sending these slides out because last time I didn't send it out because we hadn't finished it, Dr. Kumar. So I'll be sending out just now to Jody, and I'll have her send it out to you guys. Dr. Patel, it's vessel, not fessel. And that is it. Thank you all for paying attention, and I will see you all tomorrow.